Yeah. Once again, good evening all. So my case here is from no glasses to bleb. These are my abbreviations. The objectives are what could be the various causes for IOP elevation post-refractive surgeries, preoperative considerations and management of steroid-induced glaucoma. So my case is of 24 years old male who hails from Vijayanagaram, who came to our OPD on 2nd March 2023, who underwent both eyes PRK elsewhere in the last month, and after which he was started on steroids, for which he developed rise in intraocular pressure, for which he was started on AGMs and was shifted to low potent steroids. So family history, even his mother has high myopia, no family history of glaucoma, systemic history is nil. So on ocular examination, on examination of the right eye, unaided visual acuity is 20/30, and all the both anterior segment is normal, with intraocular pressure in the right eye is 31 millimeters of mercury, and left eye it is 19 millimeters of mercury, with gonio open angles, and CCT post PRK it is 408 and 406 in the left eye, and fundus disc is healthy. With this, we came to the provisional diagnosis of both eyes high myopia, post PRK and steroid responder. So what could be the various causes for IOP elevation post-refractive surgery? Coming to the first one, PRK, it could be steroid responder or pigment dispersion. Post-LASIK or femto-LASIK or epi-LASIK or smile, it could be due to intraoperative due to suction, or post-operative could be due to steroid responder, pigment dispersion and angle closure. Phakic IVLs, it could be due to retained viscous steroid responder. It could even lead to angle closure, which could be due to both pupillary and non-pupillary block, and it could be malignant glaucoma. So these are the few photographs which I had post PRK where where there is IOP elevation. Post smile due to this the patient was started on steroids, and post ICL there is pigment dispersion in this. So what are the preoperative considerations that we need to take? So we need to check thoroughly intraocular pressure, and the CCT is a must in these conditions because it is very essential for the post-op management, and gonioscopy is very must in each and every individual who is undergoing any refractive surgery, because most of the hypermetropes will have shallow angles, and there could be even pigment dispersion where trabecular meshwork could be even of grade 4, and visual fields needs to be done for the OCT, and optic disc also needs to be done, because optic disc photographs are very essential, because it is very difficult for us to assess the optic disc. Even post-op management also depends upon it. So these are the few others who studied on steroid responders post PRK. So the steroid responders varies from 7 to 12%. Coming to the management, it could be managed both medically and surgically. So how to manage steroid-induced glaucoma? So first, initially we can shift to low-potent steroids or start or augment AGMs. Even after starting or augmenting AGMs, if the intraocular pressure is normal, then we can taper steroids and continue AGMs. If IOP is still high, stop steroids and we can augment AGMs. Even after that, if the intraocular pressures are high, we can augment AGMs, either do GAT or trabeculectomy. So we augmented AGMs and started even on Repatec eye drops, and his pressures are still in elevated state. So we advised trabeculectomy, but the patient denied, and later we did left a trabeculectomy initially. So at 1 week visit, his vision is 20/80 and intraocular pressure is 4. At 1 month it is 20/50 with intraocular pressure 8. So after that we did right eye trabeculectomy where his vision is 20/60 with intraocular pressure 8, and at 1 month it is 20/80 parts with intraocular pressure 9 millimeters of mercury. So after that his intraocular pressure is maintained well. This is the timeline of the picture. So I just wanted to highlight here is preoperative considerations, better to do intraocular pressures, visual fields examinations and gonia and everything, so that it would be easy for us to manage post-operatively.
Thank you once again, but I would like to highlight a few things here. First and foremost, we now have a lot of minimally invasive glaucoma surgery available, which then, you can avoid such blebs in patients who have, probably no visual field change, although you didn't tell us about the visual field change.
Yes.
Yeah, and you see what you're now done is allowed, or put the patient at risk, lifetime risk of blebitis and bleb associated endophthalmitis. So one should really avoid, and between trabeculectomy and GAT, as you say, between that also we have many more procedures. So just unroofing the Schrems canal 90 degrees with a needle, a bent needle, if there is a problem
Bang,
with
yes.
the
Cahujual bed or-
cost,
yes.
can it works very well in steroid-induced glaucoma.
Yes, ma'am. Thank you.
Thank you.
Dr. Sivani, I would like to know, was this a steroid-induced rise in pressure or glaucoma, whatever you're saying? What was the cause?
No, what we thought here is there is no other cause for elevated intraocular pressure, so only after giving steroids only his intraocular pressure is high. Previously it used to be normal.
So probably it is a steroid-induced.
Yeah.
So it was not turning normal even after steroids have been
No,
stopped.
after even shifting to low potent steroids, after stopping steroids also still his pressures are not under control.